Hello. Let's discuss this SDL called tumors of the liver and the biliary tract. So we are into hepatobiliary now, and I would say that before you start any of these SDLs, it would really behoove you to take a good look at the normal histology of the liver particularly. It's a tricky organ. Everything kind of looks the same in it. The hepatocyte is the functional cell of the organ, and it's only until you really look at the microscopic structure of the liver that you can tell what it does. You know, it's this big chunk-like organ that you look at a liver grossly and you're like, well, what does this thing do? You know, you look at your heart and it's like, well, okay, all the blood goes in that thing. And then you look at your guts and it's like, well, all the food goes through that thing. But you look at a liver and it's like, it's not self-evident what this organ does. So you have to look at the histology to figure out that blood is going through the liver from point A to point B, and the cells of the liver interact with blood, and they do many things, right? But primarily it's a reticuloendothelial organ, which means that it's going to pull senescent red blood cells out of the blood and phagocytose them essentially and get them out of there. And it's also going to produce a lot of things. It's a metabolic organ as well. And so the liver is constantly making and breaking glycogen and fats. And it's your lipoprotein center too, right? It's like the hub for all of the fat transport in your body. And so really go zoom in on a liver and look at the individual cells and how the lymphatics are structured and where the blood flow is going. Do all of that before you crack into any of these SDLs. That's my recommendation. So tumors of the liver, not too bad. We know how to break down a tumor SDL by now. And this one's nice to us. There's some pathognomonic features of a couple of them. And for the most part, it's going to be easy to tell them apart. Difficult to remember all of the names maybe because the names are kind of similar, but easy to tell them apart. So focal nodular hyperplasia. Hyperplasia meaning a proliferation of cells. And what's going to get these cells proliferating is hyperperfusion by an anomalous artery that corresponds to the fibrotic center of these focal nodular hyperplasias. And so you're going to have this big artery that's delivering a lot of blood to a given region of the liver, and that region of the liver is going to swell up in response. And there's going to be some cell damage involved there because anytime you deliver blood, well, blood's got oxygen in it. And if you overload the electron transport chain or the oxidative capacity of a given cell, well, then it's going to reactively spit out inflammatory cytokines to cope with the fact that it's getting damaged by all those oxygen radicals. So hyperoxygenation is the mechanism here, and that's what separates that focal nodular hyperplasia from nodular regenerative hyperplasia, which we'll talk about next, which is a disease of hypoperfusion or hypooxygenation. So too much oxygen in this first one, too little in the next one. What's pathognomonic about this focal nodular hyperplasia is this stellate type fibrotic scar in the middle of this gross nodule. And you might see something similar in a different type of hepatocellular carcinoma, but for the most part, this FNH is the only thing that we're seeing that has this stellate fibrous core. So if you see it, you're thinking focal nodular hyperplasia. What's the mechanism? Hyperperfusion because of a natural vascular malformation. Here in the SDL, it's described as a depressed grayish white scar, generally but not always located at the center of the lesion. It's a stellate scar. It's pathognomonic again. And we know that this thing is not a cancer. It doesn't have malignant potential because the cells within this nodule here are polyclonal. And we know that because we looked at X chromosome inactivation of different cells within this mass, and we found that different cells had different X chromosomes inactivated. And remember, the inactivated X chromosome is called the Barr body, and the process of inactivating an X chromosome at random within a cell is called lionization. And so very, very early on in embryonic development, these Barr bodies, they're there and then they get unwound. And so there's a small period of time where all the cells in your body have two X chromosomes present and active. And then one of them randomly gets coiled back up and put away forever, literally. And so some cells of your body have X chromosome A, and then other cells are going to have X chromosome B. And remember, this only happens in females because us men, we only have one X chromosome. I guess we're really unlucky in that manner, you know? So that's how we know that these masses are polyclonal. They're non-cancerous because clonality is a feature of neoplastic growth. Now, how do these things present? Patients are typically asymptomatic. These are identified incidentally during imaging. Function tests are going to be normal, as are alpha fetoprotein, because this isn't doing nothing to your liver, and this is only really compromising or constricting a very small section of vasculature, and so no symptoms are going to come out of this. The diagnosis is made by that central scar. So we can take a quick look at a nice colorful picture here. The CT scan was interesting because it's showing you that you've got this nodule that we're seeing on the right here. That's that pathognomonic stellate scar. You can even see it, green's a bad choice. You can even see it on a CAT scan right there in the dead middle of that lesion. So real cool stuff. And last thing, these do tend to be unilocular lesions. You're just going to see one big nodule, and that is going to be a final point that will differentiate focal nodular hyperplasia from nodular regenerative hyperplasia, which is the next pathology we'll discuss. Now let's take a quick look at it before we get into the words. Notice we're seeing tiny little, again, nodules, radiopacities, a lot of little dots throughout this liver. Well, those are veins, really. That's one right up there. But the appearance of nodular regenerative hyperplasia is that of diffuse multilocular scarring. And it's very similar to cirrhosis, but how to tell it apart histologically from cirrhosis is that you don't see a very high degree of interlobular scarring. And so what that means is that in cirrhosis, you've got these circular type nodes, like there's one and there's another good one, but then you've just got these big concrete walls of collagen almost in between nodules. And you're not seeing that here. These nodules are adjacent and they don't have any divisions or partitions in between them, as cirrhosis would. So nodular regenerative hyperplasia, again, the names are tricky. You got to look at the names in order, look at the outline of the SDL to help you start telling the names apart, because that's where you'll get tripped up in this one. It's a benign transformation of the parenchyma of the liver into small regenerative nodules. And the regenerative nodule means essentially that there's been some hepatocytes damaged, there's been some injury to the liver, and when you just rip out some hepatocytes, the ones that are left will divide to fill in that hole or that damaged area. And when they do that, that's hepatocyte regeneration. And these nodules are similar to liver tissue, except for the fact that their architecture gets messed up, meaning you can replace a bunch of hepatocytes, but it's really tough to replace a central vein or a portal triad with the exact same fidelity as you had before an injury. So these regenerative nodules, the way to tell them on histology is that they don't have normal portal veins and they don't have normal central veins. So similar to cirrhosis, except the nodules do not have a surrounding rim of fibrosis. It's an uncommon condition. It's associated with anything that makes you clot, anything that makes you hypercoagulable, can give you nodular regenerative hyperplasia, because again, we said that this pathology is due to poor perfusion resulting from obliteration of small branches of the portal vein. So that contrasts it with that focal nodular hyperplasia we just looked at, which was due to hyperperfusion because of a real big artery. This one's due to real small veins, and so there's not enough blood going around. And what are some things that can make your blood more thick, that could exacerbate this loss of venules? We could have polycythemia vera. That's a high erythrocyte count that you would see if someone's overproducing EPO, erythropoietin. You could see it with autoimmunities such as lupus, RA, systemic sclerosis. You can see it with cancer. Cancer tends to make you hypercoagulable as well systemically. And finally, chemotherapy can start knocking off different cells of your liver, because your liver is your metabolic organ, your detox organ, and chemotherapeutics are very, very poisonous, many of them. And so if you are going to get chemotherapeutic toxicity, your liver is usually the first thing to go, depending on the drug. And so recognize that the obliteration of the small branches of the portal vein, well, something had to ding your liver, had to hurt your liver for that to happen. And as I said, you can replace hepatocytes very easily. You can make new hepatocytes in a week, but try growing a new portal vein, and it's like, it's not going to grow back into the exact same place as you just knocked it out of whenever there was that initial injury. And so if you had a portal vein here and a portal vein here, and you get rid of this portal vein, and then you're like, okay, I need to grow a new portal vein. Well, maybe it grows back over here, right? So then you've got two portal triads that are like really close to one another, and then you've got this big area of the liver over here that's basically got zero blood supply, you know? And so that's why the scarring forms, is because the liver's trying to fill itself in, and that's why it doesn't heal correctly, is because the vasculature doesn't grow back correctly after an injury. So multiple small nodules, again, that's different from that stellate scar one nodule. And finally, they might want to ask you, what's the complication of it? And it can lead to portal hypertension for sure, because you're occluding and constricting all the various veins going into the liver and going out of the liver as well. So you might get splenomegaly as a side effect of portal hypertension, because the splenic vein drains into the portal circulation. And so if there's a backup, then your spleen is going to be one of the first things to experience a high hydrostatic load. And also bleeding from varices. This isn't really the time or place to talk about that. You should know a little bit about that already. We'll get into it with cirrhosis, but understand that portal hypertension is going to back blood up, also into the stomach as well, up the left gastric artery, into your esophageal branches of that left gastric, and that's where the varices will form. And rupture of varices is a medical emergency with a very high mortality rate. Hepatocellular adenoma. What you really want to know about this hepatocellular adenoma is that it occurs almost exclusively in women of childbearing age. It's very, very heavily related to estrogen, oral contraceptive use, and pregnancy. Now, glycogen storage disease too, but I don't think that they would waste a question asking you about some random glycogen storage disease when there's so much else to ask about in this SDL. So yes, it's related to glycogen storage disease. No, you don't have to go spend 20 minutes studying those. Know that it's related to oral contraceptives and pregnancies, because that's what the patient's going to look like. They're going to give you a patient with a hepatocellular adenoma, and she's going to be 28 and pregnant, you know? They're telling you exactly what the patient will be in this text. So by definition, you're getting hepatocellular adenomas in a non-cirrhotic liver. And the reason they tell you that is because hepatocellular carcinomas, well, those pop up in the cases, those arise in cirrhotic settings 9.5 times out of 10. You see hepatocellular carcinoma, patients got cirrhosis somehow, some way, basically. You see hepatocellular adenoma, no, patient doesn't have cirrhosis. So that's going to help your differential, especially if it's presented in the question, oh, patient doesn't have a history of cirrhosis. Well, I don't think this is a carcinoma. So your histology shows well-differentiated adenoma cells, separated by sinusoids but lacking portal tract elements. And so your portal tract contains, your portal triad contains your portal venule, your hepatic arteriole, and your bile ductules. And you've got small portal triads and large portal triads, and your small ones empty into your large ones, essentially. And so blood's going forward through the portal triad, and bile is going backward through the portal triad out the bottom of the liver. A couple of mutations involved with hepatocellular adenoma. You've got hepatocyte nuclear factor 1A, and you've also got beta-catenin. So those are just two genes, going to be easy to remember those. There's this subtype of hepatocellular adenoma called inflammatory hepatocellular adenoma, which is associated with a systemic inflammatory response. And so to understand that, you got to know what is the inflammatory response. So every time you get sick, there's a cytokine response associated with that. Anytime there's damage or injury in a local area of tissue, how individual cells respond to that damage is by pushing cytokines, signaling molecules into the bloodstream. And one of the signaling molecules that cells really like to make in the setting of injury is interleukin-6. And the first thing you need to know about interleukin-6 is that it works on the liver. It knocks on the liver's door. Now, interleukin-1 kind of does that, but interleukin-6 is the one that tells the liver, we need you to start making proteins. And so the liver producing proteins against inflammation, that's the inflammatory response. The response is the production of proteins from the liver when it's told to do so by interleukin-6. And so what are these proteins that are produced by the liver during the inflammatory response? Well, you got CRP, C-reactive protein. And you might just think that this is something that we see on a lab panel, but actually CRP has a function within the body. Did you know CRP can opsonize pathogens? Yes. And what that means is that it can stick onto them and mark them for macrophage phagocytosis. It can tell your immune cells, hey, we've got an intruder over here, come over and do something about it. So CRP is an opsonin. So is serum amyloid A. Again, this random protein that you can measure to gauge how much inflammation is in the blood, in the body. It also functions as an opsonin. And so those are two proteins the liver makes, but the liver also makes clotting factors, which you need in the setting of inflammation because you want to be able to stop any acute hemorrhages that you might be dealing with. And the liver also makes complement proteins, and the complement system is your innate immune system, right? And so when IL-6 goes and rings the liver's doorbell and says, hey, we've got a problem somewhere, the liver says, all right, I'll make a lot more complements, C1, C2, C3, C4, C5, right? So the liver is making all of this without knowing where the inflammation is. It doesn't have to know where it is because the complement system is innate and it's soluble and it's always working everywhere. And so the liver just makes more complement whenever there's IL-6 signaling the presence of a pathogen. So the reason we talk about all this is to say that that's what happens when you have like an infection or a scrape or tissue injury somewhere. Now, this hepatocellular adenoma can start making interleukin-6 to make your liver think that there's, gangrene in your foot or something. So that's bad, because if there's not actually a pathogen or an injury somewhere in your body, then what that means is that your stress response and your immune response is getting all worked up over nothing. And we know that that's going to be injurious to the normal tissues of your body, having all that complement floating around, having all these different inflammatory proteins floating around. So the inflammatory response is also called the acute phase response, because it's the first thing that happens whenever you do get this infection or injury. You make a lot of IL-6, the liver sees that IL-6, and it's going to be making clotting factors. Most clotting factors are synthesized in the liver, and it's going to be making complement proteins and various other immunoglobulins, immune proteins. So the HNF1A gene and the beta-catenin gene. What's the complication of hepatocellular adenoma? Well, a couple that are mentioned here are shock. If it's making a bunch of IL-6 and all that IL-6 gets in the bloodstream, well, you have a massive immune response. And so what's going to happen then, I'm sorry, it's not going to work like that. It's just going to be a straight hemorrhage, because that's a very vascular tumor and it can grow very large. So that's how you can go hypotensive. It might also transform malignantly into a hepatocellular carcinoma in a minority of cases, so it's important to catch these early. Now, a hepatic hemangioma. You know what a hemangioma is. We've seen a cavernous hemangioma in the brain, and you're going to remember that it's these large cavernous networks of veins, specifically veins, not arteries. And you know that they're veins because when you look at a picture of them, they've got these very thin walls that are 1 or 2 cell layers thick. And you know that arteries have big, beefy walls, but veins have very thin walls. And so you're looking at the histology of a hemangioma, and it's going to make a lot of sense to you. Now, the creation of these venous malformations is mediated by expression of VEGF, vascular endothelial growth factor, and angiopoietins, leading to increased angiogenic activity. So that's what they look like. The only real question I feel they could ask you about this is just a simple histological diagnosis type question, or maybe a gross diagnosis with a very bloody hemangioma. The reason you want to be aware that these exist is because if you're ever thinking about going in and needle biopsying a liver and you detect one of these lobes on ultrasound, you need to understand that a hepatic hemangioma is going to have a very characteristic pale appearance on ultrasound, and on CT it's going to look a little bit differently than a totally solid mass, because this is going to be a fluid filled mass instead. And so if you catch a fluid filled mass, don't go sticking a needle into that, because that patient's going to bleed all over the place. Now let's talk about hepatoblastoma. So anytime you see blastoma, you're thinking a stem cell or an embryonic type of cancer arising in childhood. So they could ask you what type of cell does it come from, and it's going to come from a pluripotent stem cell. You might also just get asked straight up about the histology of the tumor. And so you want to know that there's going to be fetal or embryonal hepatocytes within a hepatoblastoma. But like, that doesn't float my boat, you know, because that don't tell you anything. What's a fetal hepatocyte look like? I don't know. So you got to look at pictures of a hepatoblastoma to understand what it is going to look like compared to a normal liver. And what you're going to see essentially is a bunch of small round cells. That's the best way I can describe it. That's what fetal or embryonic hepatocytes look like to me. They're normal hepatocytes, but they're a little bit smaller, a little bit denser. And this image right here is a good example of that. You can tell they've got these round nuclei, and really what's smaller about them is the degree of cytoplasm to them. They don't have nearly as much cytoplasm. Like up in here, you see a lot of nuclei, not a lot of cytoplasm. And in a way, it's reminiscent of something like Ewing's sarcoma. which is not a blastoma, but it is also reminiscent of like a medulloblastoma, remember, because that had like small round cells and cords up in the brain. And that's a pediatric tumor. And then here's another look. You've got a little bit of a well-differentiated portion up here at the top. And then down in this lower right, you see that cells are starting to get more and more dedifferentiated, a little bit smaller, a little bit more condensed nuclei down in that lower right corner. So that's what you're looking at with a blastoma. It's not going to look like a normal liver. So a couple of syndromes involved. Number one, Beckwith-Wiedemann. Number two, familial adenomatous polyposis. You should know APC by now. And this Beckwith-Wiedemann is characterized by overactivity of IGF-2, insulin-like growth factor 2. So IGF-2 is going to tell fetal cells grow, 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 divide, 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 but it's not going to tell them to differentiate. It's going to tell them stay in your stem cell mode and keep popping out stem cells. And so if you have too much IGF-2, well, then your stem cells don't grow up to be anything. They just stay stem cells and they stay divided. And this Beckwith-Wiedemann is also characterized by macrosomia because it's a stem cell overproliferation. If it happens all over your body, you know, you're going to have a big baby, and that's what macrosomia means, is a big baby. And I bring that up to remind you that the most common cause for macrosomia is gestational diabetes. When mom's got diabetes, well, then the baby is just getting sugar, 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 because mom doesn't have enough insulin to take all the sugar for herself. So baby's just allowed free reign to grow. Hepatoblastoma, again, it's a pediatric tumor, high serum alpha fetoprotein, and you've just got to take this tumor out, straight out. So that's the one that happens in kids. Okay, now the centerpiece of this SDL is hepatocellular carcinoma. It's the 5th most common cancer worldwide, and it's the majority of primary liver cancers. First thing you need to know is that you really don't get hepatocellular carcinoma unless you have cirrhosis. It's a 70 to 90% correlation of patients with hepatocellular carcinoma also having cirrhosis. And cirrhosis is basically the terminal state of chronic liver disease. And what that means is that you can approach cirrhosis from many different routes. You can get cirrhosis from a chronic hepatitis. You can get cirrhosis from alcoholic or non-alcoholic fatty liver disease. You could get cirrhosis if you had an autoimmune hepatitis. You could get cirrhosis if you had a parasite infecting your liver. You could have cirrhosis if you had a hemochromatosis. And so what I want you to understand is that cirrhosis is just referring to the scarring and the immune reaction of the liver and intent to hold itself together in the face of injury. Cirrhosis has nothing to do with the specific injury. It's referring instead to the degree of injury. So if you have hepatocellular carcinoma, what that really means is that you've had a lot of liver damage for a very long time. Now, the most common cause of hepatocellular carcinoma is going to be hepatitis-mediated cirrhosis. And alcohol's kind of far down the list. Even though alcohol is the most common cause of cirrhosis, it's not the most common cause of hepatocellular carcinoma. Hepatitis is much more common. And this SDL at the top of page 8 really walks you, gives you a primer on Hep B and Hep C before we get to those full-length SDLs. It's important to understand that neither hepatitis B nor C are directly cytotoxic. They're not causing damage to your cells just by being there. What gives you liver damage in a hepatitis infection is your own immune system, and specifically the CD8 and the NKT cell response, the cytotoxic response of your own immune system. That's what pops off hepatocytes that are infected with hepatitis virus. And so after you do some apoptosis, your neighboring hepatocytes are triggered to divide and spit out collagen. And the more this happens, the greater degree of architectural discontinuity, but also fibrotic scarring in between nodules develops, and it gets to the point where we're going to label it cirrhosis. So hepatitis B is a DNA virus. Hepatitis C is an RNA virus. We have 2 full STLs on all of the hepatitis, and hepatocellular carcinoma, hepatitis, they go hand in hand. So there's not too much to pull out of this STL in that regards, because there are others that address those points more thoroughly. Alcoholic cirrhosis, again, most common mechanism of cirrhosis. How do you get cirrhosis if you're a chronic alcoholic? Well, alcohol is directly toxic to the liver. Alcohol will uncouple your electron transport chain. Alcohol gets metabolized down to acetaldehyde. And acetaldehyde, and not only is it cytotoxic, it's also mutagenic, meaning it can take your DNA and possibly induce cancer. Because it can form adducts with DNA, and those adducts are going to stimulate mismatch repair, and whenever there's mismatch repair, well, there's a chance that you put the wrong base in, and so you got a whole new protein possibly if you don't repair that damaged DNA correctly. And I want to walk through alcohol metabolism quickly. Remember that alcohol dehydrogenase is the enzyme that takes ethanol down to acetaldehyde. And then remember that you have aldehyde dehydrogenase that takes acetaldehyde farther down to acetone. And you're producing NADH every time you spin one of these enzymes once. And so NADH is associated with the fed state because it's an electron carrier. And when you have NAD+, what that means is that it can accept electrons. And then when you have NADH plus H+, what that means is we're taking electrons to the electron transport chain. And specifically, it deposits them on sections 1 and 3, complexes 1 and 3 of the electron transport chain, right? So NADH is a natural byproduct of glycolysis of the TCA cycle. NADH is how you get metabolic energy to oxidative phosphorylation. So the fact that ethanol creates NADH when it's metabolized is no small deal, because what that means is that your body sees, your cell sees itself as being in the fed state, even when it's not. So the fact that it's in the fed state is going to, well, all of that NADH activates the enzymes that synthesize triglycerides, and it shuts off all of the enzymes that do beta oxidation or break down triglycerides. And so that's very important because that's the mechanism leading to fatty change in the liver in the setting of alcohol abuse. So all of this NADH gets your cell into an anabolic state. That's where the fat comes from. Now, acetaldehyde particularly likes to form adducts with proteins and DNA. And we know that a protein adduct, if a protein's got an acetaldehyde plastered on it, depending on where it is, maybe that protein's not going to function anymore. And so now you just have a big protein floating in the middle of your cell that you have to get rid of, you know, and that's clutter. And that's really counterproductive to a hepatocyte's intentions, because now it not only has to juggle all of the different balls that it normally does, it also has to get rid of the different junk proteins that are building up inside itself. And same with the DNA. It's just an added stress on the cell that it doesn't want to have to deal with. And if it doesn't deal with it, you might get a mutation. And that's what's going to lead to hepatocellular carcinoma. And so aldehyde is able to form adducts with proteins because it's got a very electron sparse region on that alpha carbon, on that carbonyl. When we're looking at that carbon-oxygen double bond, all of the electrons are at the oxygen essentially because that oxygen is more electronegative, and so it's pulling them away from that inert carbon. And so what that means is that anything with 2 electrons to spare can really just kind of sneak up from the back and plug itself into that carbon right there on the acetaldehyde molecule. And so now you've got, again, a nucleophilic protein or a nucleophilic part of DNA that just grabs onto that acetaldehyde relatively irreversibly. So looking at hepatocellular carcinoma, I know we're still talking about the risk factors, but here's what it looks like. You're going to see dysplastic hepatocytes, and they're going to have large, round, dark purple nuclei, and they're going to be a really weird shape, not that typical fat, lots of cytoplasm, polygonal shape, but they're going to be kind of scrunched, and they're going to be more basophilic, so they're going to be a darker color. And I'll get rid of those annotations and let you take a look at it. Then we'll pop them back up on the screen there, and it's like, yeah, those star-looking cells. Like here's another one right over here. That's clearly a dysplastic hepatocyte right there in the middle. That's another one. So judging off of the color of the cytoplasm and the density of the nucleus, those 2 factors are going to help you pick out cancerous hepatocytes from the crowd. Here's directly from the SDL. You can have a trabecular pattern, and this kind of looks like glandular tissue, you know, and I know your liver's a gland, but it shouldn't have these trabeculae in between small patches of hepatocytes like you're seeing in this image on the far left here. You shouldn't have those walls in between hepatocytes. You should see a central vein, and then you should see portal triads going out radially around it. And apart from that, the liver should have a pretty continuous histology. Here in the middle, that's your conventional pattern with pseudoglandular growth. And what that's referring to is if we zoom in really close, you can tell that there's like a duct almost, or an acinus. Kind of like if you were looking at the pancreas, or maybe even the large intestine. You're seeing a lot of secretory ducts within this conventional hepatocellular carcinoma pattern. So you shouldn't be seeing those either. So the difference between the 2 patterns is that one's got duct work, the other really doesn't. And then finally, there's this third that's kind of the exception to the other 2, which is the fibrolamellar hepatocellular carcinoma. And you see a bunch of collagen in the middle of it. So that one kind of stands out. Last risk factor we've got is aflatoxin B1, which is a mycotoxin produced by Aspergillus flavus. That's important to recognize. I hate whenever micro comes up sometimes because it's like, well, what am I supposed to do? You know, just like recite all of Sketchy to you, because it's like, what do we really know about this stuff besides Sketchy? But Aspergillus is a dimorphic fungus, and that means it's going to be a mold in the cold, yeast in the heat. It likes to get up within different foods, depending on how those foods are stored. The fungus can just grow all over it. And Aspergillus is an invasive fungus. You can get this angioinvasive pattern. You can also get bronchopulmonary aspergillosis, remember? And so once you get this fungus, it's very hard to get out of the system. So you've usually got to throw amphotericin at it. And something final that's memorable is that some fungi, you really got to be immunocompromised to get, like Candida in the esophagus, for example. You're not going to see Candida esophagitis unless someone is poorly immunocompromised. And maybe like histoplasmosis being another one. You're not going to see histoplasmosis present in someone unless they're immunocompromised, because they'll be able to fight it off otherwise. Well, aspergillus is a little bit different because of how invasive it is. You don't necessarily have to be immunocompromised to present with an aspergillus infection. It helps, you know, but like you can be totally healthy and still get this in a very bad way. And so this particular mutation, the arginine to serine at codon 249, is mentioned within here twice. I don't think they want you to remember the whole thing. I just think they want you to recognize that aflatoxin B1 manipulates P53 to switch it off. So HCC has a progression, just like how we looked at colorectal carcinoma, and that had a progression as well. So I would say just have a general understanding of it. You've got a hyperplastic focus, which is in response to an injury, namely hepatitis or alcohol. So in hepatitis, it's your own T cells that are killing hepatocytes, and then the hepatocytes that survive are reactively proliferating in response to the damaging cytokines. That's your hyperplasia. In alcohol, same thing, except alcohol is directly cytotoxic, so there's less of an immune response, more of an injury there. Both of them are going to lead to the surviving neighboring cells just blowing up in size. This can create dysplasia, which is characterized by nuclear changes and decreased cytoplasmic volume, increased cytoplasmic basophilia, like we just looked at. So this middle stretch of this timeline here, what we're really talking about is this image we just saw. These are dysplastic hepatocytes with, word for word from the SDL, increased cytoplasmic basophilia and nuclear hyperchromasia. What's that mean? It means that this cell is a little bit more pink than its neighbors, and this cell is a little bit more pink than its neighbors, and its nucleus is a little bit more purple. And that's how you spot them. And they're going to have weird contorted shapes with less total cytoplasm. So that's dysplasia, and that's the middle of this progression to hepatocellular carcinoma. And then once you get it, it's going to look like you've got images in the SDL you can check out. So then we talk about dysplasia for quite a long time, half a page. And what you really need to know is that those two changes we just talked about, mostly it's a nuclear change. You're going to see really dark nuclei in dysplasia. So now we get into the subtypes that we took a glance at. You've got conventional hepatocellular carcinoma, which can be trabecular or glandular. And then you've got fibrolamellar hepatocellular carcinoma. So grossly, the tumor might be a little bit green because well-differentiated hepatocellular carcinoma will still produce bilirubin, because that's one of the functions of hepatocytes, remember, is to conjugate bilirubin. Neither histologic pattern carries a particular prognostic significance. That sentence makes me say you're not going to get tested on anything too specific there. Fibrolamellar hepatocellular carcinoma. The only reason they introduced this to you is to show you this picture right here on the right side of the screen with this stellate nodular center. And so what you need to be aware of is that this is not focal nodular hyperplasia. This is cancer, cancer, cancer. So there's one differential for it, and you have to recognize the histology and the risk factors to be able to tell them apart. Remember that focal nodular hyperplasia is probably not going to develop in the setting of cirrhosis. Typically, it's someone who's got this arterial dilation, this big artery that is supplying a lot of oxygen to tissues, and you get damage because of all the blood flow that's going through that section of the liver. So liver cancer can be pretty fatal. It kills quite often, can kill fairly quickly. Liver failure is the most common cause of death, and also because cancers make you hypercoagulable, you might also see something like a Budd-Chiari syndrome, portal vein thrombosis, hepatic vein thrombosis, IVC syndrome, if it gets compressed, because the tumor can grow inside the parenchyma of the liver and bulge up against that IVC and decrease the blood going back to the heart. So those are the most common complications of HCC. Again, remember the genes beta-catenin, P53, aflatoxin B1 related to Aspergillus, likes to mutate P53. How do you catch this cancer clinically? Well, typically, as we've said, it's in a patient who already has cirrhosis. So they've got to establish that right at the start of the question stem. And then what they'll probably tell you is that this patient's been losing weight, you know, or maybe they're ascites, that's pot belly, basically. It has gotten really, really worse very recently. And so because you know they have cirrhosis, the first thing you're going to do is you're going to do a paracentesis. You're going to draw fluid out of the peritoneal cavity, and you're going to run a myriad of tests on it to try to differentiate the cause of this ascites. You're going to be thinking maybe it's a bacterial peritonitis, right? You're going to be thinking maybe they're going into liver failure, and then you're also going to have cancer on your differential. And so if you see something like blood in that peritoneal tap, then the reason why a cancer would lead to blood in the peritoneal tap is because of all the vasodilation associated with cancer. And it does kind of damage capillary beds, damage small arterioles, kind of shreds them up and gets them to become leaky and more permeable. And so you can spill blood into the peritoneal cavity if a tumor is growing on the periphery of the liver. And what you'll see in the blood is a high alpha fetoprotein. Pretty non-specific finding, just be able to correlate AFP with liver pathologies. And that's mostly for boards, not for our in-house exams. They're not going to ask you something as easy as AFP on an in-house. Last point, hepatocellular carcinoma is commonly diagnosed on the basis of imaging alone without histologic confirmation. Because you're going to put together the clinical, oh, this patient has lost 20 pounds in a month, or, oh, this patient's just gained, 2 liters of fluid in their belly in 2 days, and you're going to put that with the imaging findings, which is basically going to be a liver with marbles in it, pretty much. And that's going to make your diagnosis because you're just going to connect the dots together in your head. So metastasis to the liver is very common. Likes to go through the bloodstream, likes to come from the GI tract, the stomach, the pancreas. Colorectal cancer likes to go to the liver. So we had colorectal cancer on our last exam. Remember, the number one risk for that's red meat. Another risk for that's low fiber. So I could see the question going like, here's the tumor in the liver, here's what the histology looks like, and they show you the histology and you go, oh, that's not a primary liver tumor. And so then they ask you, well, what's the gene involved, or what's the risk factor involved? And so because we've had all those things fairly recently, and it's a lot, like I can't help you with this question. I can't help myself with this question. You can only hope that you remember enough to be able to get the metastasis correct. Metastatic neoplasms are the most common tumor in the non-cirrhotic liver, but are extremely uncommon in the cirrhotic liver. Thus, in a patient with known cirrhosis, a malignant neoplasm is almost always hepatocellular carcinoma. And my understanding of this is that when you've got cirrhosis, it's harder to get blood into the liver. You've got really high pressures in the liver. Blood doesn't want to go into the liver. And so, well, are you more or less likely to get hematogenous spread of metastasis when it's harder to get blood in the liver? Way less likely. And so that poor perfusion is what creates this difference in metastasis between cirrhosis and non-cirrhosis. Let's talk now about the biliary tree. A couple of cancers. Cholangiocarcinoma is the first one we will discuss. It's a very sneaky cancer, and patients don't have a lot of time after they get diagnosed with this. Now, it can pop up inside the liver or outside the liver, and that should make sense because this is a cancer of cholangiocytes, which are the epithelial cells lining bile ductules. And you ought to remember that you've got bile ductules investing the entire interior of your liver, but also going out of the liver and traveling down and joining with the cystic duct, which connects to the gallbladder to form the common bile duct, which is then going to join with the pancreatic duct to form your hepatopancreatic ampulla that's closed up by that sphincter of Oddi. And right on top of that is your ampulla of Vater, which is your major duodenal papilla. And so the contents of the bile duct plus the pancreas spit out into the duodenum. So lining that entire length of ductwork are cholangiocytes. And so you can develop a cholangiocarcinoma anywhere along that tract of bile duct. Although they're most common at a particular location where the right and the left hepatic ducts join with one another. So what does that look like? It's called a Klatskin tumor. Here's what it looks like. And actually, we're going a little bit backwards with this one, because this one's saying A is the common bile duct. In this image, A is common bile duct. And this one said that B was the right hepatic duct, which means that blood would be going, or bile would be going this way. And that means that the duodenum is up in this particular image. But there's your gallbladder. There's the cystic duct going down and merging to make the common bile duct. There's your hepatic duct. And so here is your tumor right there where the right and left hepatic ducts merge. And so that's what we're talking about when we reference a perihilar cholangiocarcinoma. So what are the risk factors for this tumor? Well, liver flukes, Clonorchis sinensis is the big one that we're aware of. And these actually have humongous rates in parts of Southeast Asia. Cholangiocarcinoma's got a less than 1 person per 100,000 incidence in the United States. But in Thailand, I read that it's 60 people per 100,000 per year. So literally a 100-fold increase between those two different countries. And it's largely due to the presence of this liver fluke within water supplies, because it's usually fecal oral. Remember that the snail's an intermittent carrier, and snails live in water. So people draw up water and they might drink it and get this parasitic infection with Clonorchis sinensis, which likes to give you pigmented gallstones. And gallstones are going to obviously abrade and damage the interior lumen of a bile duct and encourage the development of this particular cancer. Primary sclerosing cholangitis is also a predisposing factor, the most common predisposing factor in America. You can also get it, just basic gallstones increase your risk for cholangiocarcinoma. So I could see a micro question getting spun out of that, or I could see just, you know, what did this patient most likely have? And the answer is just gallstones really easily. Then we discuss at the bottom of page 12 the sequence of dysplastic changes that lead from a pre-malignant precursor lesion to cholangiocarcinoma. And this is not the most important thing in the world to learn. I actually didn't even throw that photo in my slides. Just eyeball it, you know. And if the question really is this a neoplasia 1, 2, or 3, you know, just take your best guess. And it's okay if you get this question wrong, because it's like, do you really want to spend 10 minutes memorizing this? You can if you want. This one looks pretty normal, you know, and it's like these cells are getting a little bit darker, and then these cells are obviously not normal whatsoever. So it's not that bad. So grossly firm white gray tumors can be pretty large. You're not going to have to make a gross diagnosis. You're going to have to make a histological diagnosis. So cholangiocarcinomas or adenocarcinomas usually, because again, the bile duct has these nice cuboidal cells, and it's a gland in its own, I guess you could say. And it's going to have this desmoplastic reaction, which means there's going to be a lot of fibrosity within components, glandular components of this tumor. So there's a broad differential for cholangiocarcinoma, including gallbladder cancer and pancreatic cancer, and also metastatic adenocarcinoma from the esophagus, which drains into the liver, and the stomach, which drains into the portal system. So, I mean, I don't know what they're going to ask us here, honestly. They could make this question hard as all get out if they wanted to, or they can make it really easy. So I just say, know the genes for cholangiocarcinoma, because that's what this exam's on. And this is the only cancer in this whole SDL that really does have some individual genes associated with it. We've got HER2 and we've got KRAS beyond the standard P53. You know, P53 is involved in all of these different cancers, but HER2 is an epidermal growth factor receptor, and KRAS is a GTPase. And remember that growth factor receptors basically encourage the cell to go through G1 faster. And KRAS is a signal transducer that is also going to get the cell going through G1 even faster. And there's another gene, this SMAD4 gene that we've seen before. Can't remember where, but we've seen it. It's actually called DPC4, which is deleted in pancreatic carcinoma 4. And this SMAD4 gene provides a cell with TGF-beta signaling capabilities. And when a cell spits out TGF-beta, it can turn around and in an autocrine manner act on that cell that just produced it to get that cell to stop where it should at that cell cycle checkpoint. Because it's really good for a cell to be able to do that. You know, you can reevaluate, you can take stock of your situation if you're a cell. You can say, oh, hey, do I need to apoptose? Do I have any DNA damage? Am I ready to go straight ahead? Do I need to synthesize anything else before I do? And so TGF-beta is a molecule that's going to encourage that reevaluation on the part of the cell. So if you don't have TGF-beta, your cell's just like, YOLO, I'm going to S phase, you know, like I'm living life. And so if you skip that stop phase in the cell cycle, well, then again, you could have a mutation and maybe you should have apoptosed and you didn't. Why? Because you didn't have any TGF-beta. So that's what that gene's doing. Anytime you see TGF-beta involved, understand that it's a good thing for cells to have TGF-beta and that it's, what's the word? Carcinogenic, encouraging cancer if you don't have any TGF-beta. And this cholangiocarcinoma, you might also see isocitrate dehydrogenase mutations. And once you see IDH1 and 2, you need to be thinking methylation, like Pavlov's dog. Because histone demethylases require alpha-ketoglutarate. And alpha-ketoglutarate is produced by isocitrate dehydrogenase. So if you're not making alpha-ketoglutarate, histone demethylases aren't working, meaning your chromatin stays unwound, potentially resulting in epigenetic alterations. So that's another way of picking up mutations. I got any pictures for this? Yeah, I got some histology for this. So cholangiocarcinoma, before we talk about how it presents clinically, let's look at it under the microscope. We're seeing gland-like ducts, indeed, with these cuboidal type cells. And we are also seeing that serous or fibrous intracellular component to it. And if it is an intrahepatic cholangiocarcinoma, you might see many hepatocytes in the field of the tumor if it's a low power shot. So what that's going to tell you is like, okay, this can't be a gallbladder cancer. That's what's going to differentiate this from a gallbladder carcinoma, is if you see hepatocytes. but you might not see hepatocytes. Cuboidal epithelial cells, those are the cancerous cells. So patients who have a cholangiocarcinoma can present one of two ways. They can be jaundiced or they can be not jaundiced. That's it, basically. And if they're jaundiced, it's because of an obstruction, which means they're going to have a conjugated bilirubinemia and their alk phos is going to be up. And if they're not jaundiced, they're going to have a normal bilirubin and their alk phos is going to be normal. But what's common between the two of those is that serum CA19-9 is going to be elevated. So remember that. So it spreads by direct invasion. Extrahepatic metastases are often found. Can lead to multiple organ dysfunction. Therapeutic options are limited because this cancer is typically very far down the line by the time we catch it. And I'm not sure what the main cause of death is, but if I were to guess, I'd probably say liver failure. Maybe something like portal hypertension, maybe pancreatic failure. So gallbladder carcinoma is the last cancer in this SDL. It's uncommon but highly fatal. The majority are found incidentally. And a couple of risk factors you need to know. Number one, gallstones. Number two, Salmonella typhi, which likes to get up in the gallbladder and infect it. And Salmonella typhi is endemic in Asia and South America. It means it's native to that geography. Porcelain gallbladder is also a risk factor. And that's a easy thing to spot on an X-ray or CT. You can tell that's exactly where the gallbladder should be, and it's just encrusted in calcium, basically. There's an X-ray of it. So you see this, you're thinking gallbladder cancer. And visually, gallbladder carcinoma is looking very similar to cholangiocarcinoma, meaning the cancerous cell is this cuboidal epithelial cell. Maybe a little bit more columnar in the gallbladder, but really what helps me set this apart from cholangiocarcinoma is the lamina propria of the gallbladder is similar to the lamina propria of, say, the intestine or the stomach. Especially right here in this image. I mean, look at those lymphocytes and small fibroblasts in between glands. It's practically like you're looking at the stomach right there. And here as well, there is so much collagen in between these very large ducts, and you don't see a hepatocyte in sight. So you might be more prone to say gallbladder carcinoma in that setting. Also, there's a mucinous goblet cell. There is a mucinous goblet cell. You make a lot of mucin in your gallbladder. You don't really have goblet cells in your liver or in your bile duct. So that's how I tell the two apart as best as I can. Again, if you see hepatocytes, it's cholangiocarcinoma. It's not a gallbladder carcinoma. So getting back to it, a handful of risk factors and a handful of carcinogen exposures. If they really want to ask us about that, like, cool, okay, sick. The larger the stone is, the more likely you are to get gallbladder cancer. So it's like, what's the most important risk factor? Size of the gallstone, not just gallstones. Most of these are adenocarcinomas. They tend to be located in the fundus of the gallbladder, which is like the hat or the top of the gallbladder, the side that's farthest away from the duct. Grossly, they can be infiltrative or papillary, and that's just referring to, is it growing out or into the gallbladder? If it grows into the lumen, it's your papillary type. If it grows out into the wall, that's your infiltrative type, kind of analogous to how you've got polypoid or annular colorectal carcinomas. It's a serous cancer, just like cholangiocarcinoma, so it's tough to tell it apart there. And that's the real differential for it. That plus pancreatic carcinoma, which we're going to cover in a later SDL. So the cancer questions on this exam might not be a lot to sneeze at. Mural thickening of the gallbladder, they could just tell you that with words, or again, they could show you that CT of the porcelain gallbladder, and that's a dead giveaway for gallbladder carcinoma. So that's all that we got here. Our kind of a long cancer SDL, I thought 16 pages. What I would like to touch on again is probably hepatocellular carcinoma and these risk factors. I know I got a little off track and I went to the PowerPoint in the middle of that. And so I want to just talk through how you get hepatocellular carcinoma one more time. If you've got hepatitis, so you get the virus, right? And then the virus gets inside your hepatocytes, and then your immune system recognizes, hey, these cells are infected. And so it comes through and it pop, 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 blasts all of those infected hepatocytes as best as it can. And when it does that, there is a ton of interferon gamma thrown up into the air, you know, ton of TNF alpha thrown up into the air. And so all the liver cells that are normal are breathing in all that interferon alpha, gamma, and TNF alpha in the region. And they're saying, oh my word, I've got to proliferate. I have got to throw down collagen. Because then there's also going to be like your M2 macrophage response after that apoptosis has occurred that's going to encourage the deposition of collagen through TGF-beta. And you get scarring up of the liver, and your hepatocytes divide. And well, the more they divide in response to injury, obviously the greater chance of picking up a mutation in one of those dividing cells. Alcohol, same thing. You get an injury, and then your liver takes care of the injury. Maybe the damaged cells just turn necrotic, or maybe they go through apoptosis. But the point is, after the injury, to fill in that blank space, normal hepatocytes are dividing. So the fact that they're dividing so much, plus the fact that they possibly have acquired genomic mutations, is what leads to cancer. And in alcohol, the mutational component, the mutagenic component, is the aldehyde adducts. And in hepatitis, well, these are DNA, RNA viruses. They can kind of splice up your DNA a little bit and inject parts of themselves into your genome potentially. So that's a mutagenic potential there too. And indeed, we see at the top of page 8 here, Hep B virus DNA is integrated into cellular DNA in 90% of Hep B related hepatocellular carcinomas. So it's the integration of that Hep B DNA into a host cell DNA that is promoting mutations. Big gene P53. Hep C RNA virus can't get into the host genome, but it is going to cause a chronic inflammatory state that's going to get the immune system reacting against those cells and cause a large degree of inflammation and necrosis in the process. So nothing really specific about Hep C. Just recognize that it's highly correlated with cancer because Hep C never goes away once you get it. You're stuck with it. Well, that's about all that I got. Thanks for learning.